machine is there, so that my needle is coming from cranial to caudal and I am seeing from here. Okay. So I am just starting my probe over here. I start with the clavicle. So this acoustic shadow, that is this clavicle. Okay. If I am coming down, now I can see two muscle belly basically. That is, one is pec major and another is pec minor. Okay. So if you just move a probe right here, below the pec minor, I can see there is a muscles. There's a rib, second rib. You can see there. I'm just moving my probe right there. There's a third rib. See here you can see right in between the pec major and minor, there is small pulsation right there. So this is nothing but the pectoral branch of thoracoabdominal artery. That one of the landmarks that normally correspond that lateral pectoral nerve accompanies with this. So this spleen is basically for the interpectoral block that covers your medial and lateral pectoral nerve. Okay, this is the pec major. So once I'm going down at the level of fourth rib, now you can see at this level there is another slip of small muscles has started ordering right there. At the edge, so this is nothing but the serratus interplane muscle, serratus inter muscles. Okay, so this is the pec major, minor is now thinning out. This muscle is nothing but the serratus interplane muscle. So once you can see muscles, if you follow it towards the lateral chest wall, so that you can identify the muscles right there. I'm coming here. Okay, right there. So same muscles, I can see the muscle just above the rib is nothing but the serratus. Okay, so once you come to the thorax, the lateral wall, it's become more and more thicker. Okay, it become more posteriorly. Now another muscle that is there is latissimus dorsi. Okay, the other one. So starting from here, major, minor, serratus and the latissimus dorsi. So basically you can identify each and every muscles and individually decide the planes where you want to do. So if I am doing a pec, interpectoral pecs block, I can starting from here, right there and sitting here, I can. Okay, so here I can just take float a probe. My needle is coming from cranial to caudal. I can see this spleen. Either you can deposit just hitting the rib. So it is always safe that you can see there's a rib right there. So your needle is coming here. So even if you are going to hit this, then you are not going to hit the pleura. Okay. So you can deposit over here or at this plane, just below the pec minor. So that might be a superficial or the deep planes. And you are coming back. This is your interpectoral group area. So there's the pec one or there's the interpectoral block that is given. Okay. So based on this, whether we are going superficial or the deep, there is two structure that normally for a dorsal or long thoracic nerve. So basically these two motor nerve, these nerve are blocked when you are depositing at the superficial plane. Okay. So here you can see this is the serratus muscles. Okay. Suppose I am going only planning for serratus plane only block. So in that case I can see just putting my patient like this. Okay. Okay. So it's a very thin one. Okay. So this is the mid axial line. This is the anterior line. This is the probe. You can see this is the muscle that is the thick muscle that is the latissimus dorsi, and you can see a artery right just at the below that. So this is nothing but the thoracodorsal vessels. Okay, and the muscle just lying over the rib is serratus. So you can see the different fibers. The serratus muscle is like this. So this the fibers are along that superficial plane. That's the superficial plane block that normally along the lateral intercostal branches block the long thoracic and thoracodorsal nerve. But if you are going deeper one, that is going to block the lateral intercostal branches, leaving these two motor blocks. So these are basically the two planes that is normally described for this. Okay. So in this case, if you see again there is a bone and the rib is there, you can hit the rib and open up this plane. The drug is beautifully spread in this plane. Okay. this two is there. Okay. So I'll just show this.
So this always the hemicurrence block is based on this, depending on how to select the block. It's basically an individual nerve basically which is covered with each block.
So once you identify the plane, it is easier to do the block as I said in the next row. So again the data is coming from cranial caudal. You can see that pec major, minor and the lead is the vector always the same. So that you can just place the needle close to that. Sometimes you can just open up the plane between the pec minor and the serratus. And then when you come back, you can just start with the interpectoral nerve. Okay. Sometimes individually might be sometimes you need that interpectoral group block. So in that case, you can just do for that. And the second one is basically, as I said, the serratus interplane block. Sometimes if you see the before positioning, sometimes always feel some difficulty to do some maneuver. You can see that mid-axial line can be opened up beautifully. So even if in a morbid obese patient, also try to find the lead so that you can just go and hit that. If you're not able to feel the superficial pain, actually the deeper pain also gives a good amount of anesthesia. And you can see the drug normally 20, 30 or 40 ml has been taken study showing that more or less it is going to cover up depending on that whether the superficial pain bit of getting more spread, the deeper at least T2, T6. So T3 is normally this is the spread is drug is there. You can see the scan once you give a drug, cranial caudal, the drug is sprayed in that plane beautifully. So in this case, at least you can just a good opioid sparing and the separation when you think that the patient are not going to do opioid or some issues related to that. Thank you. Next.
That was an insightful lecture. And now we move on to our next session of abdominal blocks. The abdominal blocks will be covered by Dr. Ghanshyam Vyani. He is an associate professor in AIIMS Mangalgiri, and Dr. Amrita Rai. She is an associate professor in BHU. Thank you, Dr. Hina, for that kind introduction. So for the next couple of minutes, we will sail through the important abdominal wall blocks. So when we talk about the anterior abdominal wall, we mainly deal with 4 types of vessels and both are paired. The middle one being the 2 rectors on either side, and the lateral are from superficial to deep are your external oblique, internal oblique, and transverse abdominis. So first we have to understand the cause and the nerve that supplies the anterior abdominal wall. So after exiting from the intervertebral foramina, the ventral rami of the thoracoabdominal nerve initially sells through between the psoas and the quadratus lumborum muscle, and then it enters into the tapetum, that is between the internal oblique and the transverse abdominis. However, in the near the mid-axillary line, it gives a branch, that is the lateral cutaneous branch, and again it splits into 2, which supplies the anterolateral abdominal wall. And it itself continues, and then it pierces the rectus abdominis muscle, and it divides to supply the anteromedial abdominal wall. Based on the plane where it is innervating, the blocks has been described. So for the anteromedial abdominal wall, it is the rectus sheath block, because as we can see the intercostal nerve, it pierces the rectus abdominis muscle. It lies for a minimal time. It lies between the posterior rectus sheath and the rectus muscle, and it supplies the cutaneous branch. Similarly, also we have to understand when it gives the lateral cutaneous branch, we say there are two blocks. Tab block, that is the transverse abdominis, is either a subcostal or a mid-axillary approach. Why this term is given and when to be chosen is depends on where it is giving the branch. So, commonly performed block in the anti-abdominal wall is the rectus sheath block, that is for your anteromedial or the midline surgeries. For the lateral, we have the transverse abdominis plane block, either the subcostal, if the incision is typically between T6 to T9. If it is below umbilicus, we choose the mid-axillary tab. Especially for the inguinal lesion, that is L1, we pick up the ilioinguinal iliohypogastric, and there is a very newer block which is widely used and highly effective block which provides both somatic as well as the visceral analgesia, is the quadratus lumborum block. So in the rectus sheath block, one important, this already I have highlighted here. So you can see once it is lying between the internal oblique and the transverse abdominis, then this is the linea semilunaris, then it will come, pierce the rectus abdominis muscle and provides the cutaneous branches. And here we are trying to block when it is lying in a very short distance between the posterior rectus sheath and the rectus abdominis muscle. This is a very important concept which you have to understand, that there is a line called as the arcuate line, which lies, it's 1/3 between the umbilicus to the suprapubic line. So this line has an importance in case of a rectus sheath block, that the below the arcuate line, the posterior rectus sheath is deficient. So if you look at the formation of the rectus sheath, it is at three places. One is the variation when it is above the costal margin. Second is when it is above the arcuate line, and third is when it is below the arcuate line. So above the costal margin, if you can see, it is the aponeurosis of the external oblique which form the anterior wall, and posterior wall is deficient. This is the most important for us because we are dealing with the rectus abdominis block above the arcuate line. So it is here the internal oblique will split into two. It will form an anterior lamina and a posterior lamina. So the aponeurosis of the external oblique muscle plus the anterior lamina of the aponeurosis of internal oblique, that will form the anterior rectus sheath. Similarly, the aponeurosis of the transverse abdominis and the posterior lamina of the aponeurosis of the internal oblique will form the rectus abdominis, posterior rectus sheath. So when you are trying to consider the block below the arcuate line, the posterior rectus sheath is absent, as all the aponeurosis of the three muscle is forming the anterior rectus sheath. So you need to be very careful, because if you penetrate deep, you are going to injure the peritoneum directly. Also, there is one important vessel here, that is your inferior epigastric artery. So always try to locate while you are scanning. So this is how we perform, and I will directly go to the anterior abdominal wall block, we do the scanning and come back. So here you have to pick up for the anti-abdominal block. Now I am going to demonstrate for the rectus sheath block, the mid-axillary block, and facial transversalis block. Okay, mid-ilioinguinal and iliohypogastric. So all the named blocks I will pick up the linear probe. Where to place your probe? Between the xiphisternum and the umbilicus you can put. So the structure which you see in the midline is the linea alba. And on either side you can see two muscles, big bellies, they are the rectus abdominis muscle. So when I am trying to move to the either side, so what muscle, the bigger muscle you appreciate here is the rectus abdominis The down hyperechoic line which you appreciate here is the fascia transversalis. So what people do mistake is they feel the drug should be injected between the two. It's not the concept. As I mentioned, the nerve travels between the linea semilunaris and it pierces between the posterior rectus sheath and the rectus abdominis muscle. So the ideal position of drug, you have to deposit the drug here between the epimysium of the rectus abdominis muscle and the posterior rectus sheath. And where exactly you have to deposit your drug is on the lateral side of the rectus abdominis muscle, because in the same plane the nerve will pierce and exit to give the cutaneous branch to supply the anteromedial abdominal wall. Okay, from here. So after you understood this, so when I'm moving, trying to put my work upright lateral, can you see the appearance of another muscle here? So this is the transverse abdominis muscle. So when you see the transverse abdominis muscle, again you can appreciate another aponeurotic thing here, that is your linea semilunaris. Lateral to the linea semilunaris, when you move down, this is your transverse abdominis muscle. Okay, this is your linea semilunaris. So as you move down, from here you will appreciate the appearance of three muscles here. External oblique from superficial to down, the thickest is the internal oblique, and then down is your transverse abdominis. So here the two tab has been described. So literature there was multiple names to remove the ambiguity. There are simply two tabs. One is a subcostal tab, other is a mid-axillary tab. Above the T10, go for a subcostal tab. Below the T10, go for a mid-axillary tab. Again, exactly why do we deposit the drug cutaneous or the sensory, when you need a sensory block of the lateral abdominal wall. Okay, so from here I move my probe more posteriorly. So I move my more posteriorly. So can you appreciate it here? Now currently I am in the, if you see my probe position, it is currently in the mid-axillary part. Okay, that is between your costal cartilage and the iliac crest. So I have to deposit my drug between the transverse abdominis muscle, that is the innermost, and the internal oblique, that is the thickest. These are the facial pain block, where analgesic block, high volume block, low concentration block. Still, don't take it at ease. They are at a very high risk of causing local anesthesia systemic toxicity. Okay. So if I further trace it posteriorly, can you see the transverse aponeurosis? Can you see the transverse abdominis is coming to a halt here, okay? And for a very short distance, it is forming a aponeurosis, okay? And below, what you appreciate here is the fat. This is the retroperitoneal fat. And there will start the formation of the QL muscle, which will appreciate with the help of a curvilinear probe. So when you see the aponeurosis of the transverse abdominis muscle and down the retroperitoneal fat, the aponeurosis of the internal oblique transverse abdominis and the fascia transversalis is very adherent to each other. So once you start hydrodissection, you will see the transverse facialis going down. That is why you perform the transverse facialis pain block, which is very effective for iliac crest surgery. Especially when we do a fracture forearm, they want to take the graft harvesting for the grafting. You can use this block. So you can upper limb block plus a fascia transversalis.